Hi, dentist again. This is Mohammed Musa from AFK Study Plan. We're gonna continue with what we started about the management of fracture or trauma. You can check here the first article about the management for the primary dentition. I think I would recommend you to watch it before watching this one because it's a story building up. So please watch it again and come here. Okay, so in this article, we're gonna speak about the same concept, but like speaking about the permanent dentition more, and it's the same, but like speaking in different terminology and in different scenarios. Okay, as usual, get your notebook, get your pen, put your notes, try your best to answer the question coming into your screen, and feel free to share the video. Okay? Okay, so he's speaking about here the majority of the trauma dental injuries happening to children and teenagers, as we said before, and then result can be a fracture or displacement of tooth, crushing of bone or soft tissue injury. We speak about this before. He speak about the X-ray here and recommendation for X-ray, which X-ray to be taken. And without wasting more time, we're gonna go to scenarios right away. Okay, so first of all, crack or craze line. Crazing is like a crack on the tooth, no sensitivity to percussion, no palpation. Evaluate the tooth, no x-rays needed, nothing. You just normal mobility, not tender to percussion, everything is good. You just see a crack on the tooth. You speak to the patient about it. There is no need to do anything about it. You just deal with him. In case of severe infraction, etching and sealing with bonding resin should be considered to prevent discoloration and bacterial contamination of the infraction. Otherwise, no treatment is necessary. And then again, you should explain to him. Now we're speaking about permanent teeth, so he might come with his parent by himself. You should speak with him or with his parent or legal guardian about the favorable outcome and unfavorable outcome and tell him what he will see in the next few days. Okay. Second, if you have a coronal fracture, so enamel is lost now, enamel part is broken, loss of enamel, but there is no visible sign of exposed dentin, and then you evaluate the tooth, maybe luxation injury, maybe some concussion and stuff like this. If it has normal mobility, everything is good. Enamel loss is visible, you can see it, so missing fracture should be accounted for. If fragment is missing and there are soft tissue injuries, radiograph of the lip or the cheek are indicated to search for the tooth fragment and or foreign materials. So we mentioned this before and we mention it again here in a clear terminology. If you see a tooth part is lost, you cannot find it, and there is a laceration in soft tissue, you should take x-ray for soft tissue to check for it. And for sure, if you cannot find it at all, you should send him to emergency. They take chest x-ray to deal with him. And then if the tooth fragment is available, it can be bonded back on the tooth, or depending on the extent and location of the fracture, the tooth edge can be smoothened or composite resin restoration placed. So if you have the broken board, so you can just cement it back, or if it's not here, if you cannot cement it back, if it's fractured to extent that you cannot re-cement it again, so you can use composite restoration to build the tooth again. Follow up after 6 to 8 weeks, 1 year, and there's give him the idea about favorable outcome and unfavorable outcome. Okay, and then next step, I think you can guess it, enamel and dentin. No mobility test is usually positive, no sensitivity to percussion or palpation. Tooth is good. So you now have a situation where is enamel and dentin. Enamel is broken, dentin is exposed. Missing fragments should be accounted for. As we said before, x-ray should be indicated if you cannot find it. If tooth fragment is available intact, you can re-cement it again, bond it with resin, with composite. But if it's not present, you can cover exposed dentin with glass hammer and then use composite to build the tooth again. And if the dentin exposed within 0.5 millimeter of the pulp, pink but not bleeding. So just use your imagination here. Think about it. I saw before. It's amazing, honestly. You see the patient sitting on the chair. You look inside the tooth, and you see broken enamel, exposed dentin, and you see pink. You see pink spot, but no bleeding. So you can see the shadow of the pulp. You can see the shadow of the pulp, but you cannot touch it. I think you can imagine it now. In this situation, place a calcium hydroxide lining and cover with materials such as glass hammer and then cover it with a composite. So a question for you here. So why we cannot put glass hammer in very deep Dentin, like very close to bulb. I think you can know the answer. I've composite, the same answer. You think about it, I think you can get it. Okay. If you don't know it, write for me. I will answer that for you. Okay. And then clinical examination should be rebook again after 6 to 8 weeks, 1 year, and then you speak about the patient, about the favorable outcome, unfavorable outcome. So the new idea here is this one. If the exposed dent is within 1.5 millimeter of the pulp, pink but not bleeding, so calcium oxide first, the glass hammer, and then composite to build the tooth up. Okay, so what do you think the next step is? Voila, you got it. Enamel dentin and bulb exposure is here. Okay, again, missing fragments should be accounted for. If it's missing, you cannot find it, just soft x-ray, and then you can refer him to emergency. In patient where teeth have immature root and open apexes, it's very important to preserve the pulp. Partial pulpotomy or pulp capping are recommended in order to promote the further root development. So, and this is a new guideline. I think most of us don't know this guideline. So, again, as we mentioned in the previous article, and in this article, again, it will be stated at the end. So the most important part of dealing with immature permanent tooth is to reserve its vitality. And even for permanent tooth with mature roots, to preserve its vitality is the main goal for evidence now. So it's very important to preserve a pulp. So partial pulpotomy or pulp capping are considered. So if you have a bleeding happening and you see exposed pulp, what's the meaning of partial pulpotomy? You use your excavator just to excavate 3-4 millimeter of soft tissue till bleeding is controlled, and then you restore it. You restore it with non-static calcium hydroxide, glass hammer above it, and composite to build the tooth. Or conservative pulp treatment, partial pulpotomy is also the preferred treatment in teeth with complete root development. So this is the guideline, the new guideline here. Catch up, please, with me. So if the question saying 25 years old, adult, he come to you, he has trauma, and the one is broken, and you can see the bulb. It's complete. It's the root is completely developed. Like it's 25 years old for sure. The root is completely developed in this area. If the tooth is indicated for pulpotomy, partial pulpotomy is a treatment to be done. Okay, non-static calcium hydroxide or non-sitting calcium sulfate cement are suitable material to be placed over the bulb wound, and then you put a glass hammer, and then you put composite. Crown is indicated if the fracture is too big and you cannot restore it with composite only, and if the tooth fragment is available, you can bond it again with the use of flowable composite. Okay, follow up 6 to 8 weeks, 3 months, 6 months, 1 year, favorable outcome, unfavorable outcome. So the new guideline here is this one. Conservative pulp treatment is also preferred treatment in teeth with completed root development. Okay, it's not only for immature tooth. Okay, and then this scenario we speak about it before. It's like if enamel, dentin, and cementum extending into the soft tissue. First of all, missing fragment should be accounted for. If you cannot find it, take X-ray for it. What X-ray is needed is 1 PA, parallel radiograph need to be done. Cone beam CT can be considered for better visualization of the fracture path, its extent, and its relationship to the marginal bone. Also, useful to evaluate the crown root ratio and to help determine treatment option. So this is a new point. Please pay attention for this one. So we mentioned before in the previous article, cone beam CT is really indicated for trauma. Okay, this is a situation where it's indicated. Really mean like it's not obsolete, not contraindicated. It can be indicated in some situation. So why we need cone beam CT here in this situation? So think about it. Same the patient previous. He came to you. He's 25 years old, and the fracture extending beneath a soft tissue. So why you take a cone beam CT? Because like you have more than one line of treatment. This line of treatments, including that you do crown lengthening and you do a crown for this tooth after doing RCT. So before you decide to do this, you should make sure the crown root ratio is good. How you can make sure the crown root ratio is good? Here come cone beam CT can give you the exact information about it. So again, it's not usual to choose this option for trauma, but the scenario is complicated here. So and this is advice for you in the exam. When you see a question, you don't jump to conclusion. You read the question very carefully because one small change, age change, boom. Like brain level change, boom. pain lingering, not lingering, boom. So it's totally different answer. Same question, just want to change, totally different answer. So this is a scenario when we use cone beam CT for trauma, okay? Until a treatment plan is finalized, temporary stabilization of the loose fragment to the adjacent tooth or teeth or to a non-mobile fragment should be attempted. So before they let the patient go, okay, we're gonna go do cone beam CT, let's go home now. No, you should take care of him. If the bulb is not exposed, removal of the coronal or mobile fragment and subsequent restoration should be considered. Cover the exposed dentin with glass ionomer and use of bonding agent and composite resin. Further treatment option. The treatment plan is dependent in part on the patient age and anticipated cooperation. Include orthodontic extrusion of the apical or non-mobile fragments. So in this scenario, we speak about like you remove this part. So the broken part, go to garbage. You remove it. So what to do now? You have two solutions. First of all, orthodontic extrusion. Orthodontic exclusion of the apical or non-mobile fragment followed by restoration may also need periodontal recontouring surgery after extrusion. This is a fancy way to say crown lengthening. Or surgical extrusion. So when you do surgical extrusion, if the fragment, you need to do it more. So what's the difference between orthodontic extrusion and surgical extrusion? It's very simple difference. Orthodontic extrusion will take more time, but more favorable because it's gradual. Surgical extrusion, you mean like extra surgery for your patient, and it requires the patient is more cooperative with you. He can endure another surgery. So this is the difference between them. You can use this or that. Root canal treatment and restoration of the bulb become necrotic and infected. Root submerge, intentional reimplantation with or without rotation of the root or extraction or auto transplantation. So he's giving you the all scenarios here, but like what's really important here, you should know like ortho extrusion or surgical extrusion is option to be done, but yet you should consider the crown root ratio. So if the crown root ratio is 1:1, extraction here is that line of treatment. If the crown root ratio is favorable, you do it cone beam CT and it's good, so you can follow up with the treatment you need. Okay, clinical follow up 1 year, 1 week, 6 to 8 weeks, 3 months, 6 months, 1 year, and again, favorable outcome or unfavorable outcome. The patient should be aware of it. You don't do treatment for patient and let him go and he come to you ask you question. You should let the patient know what he will see in the next few days. And to be honest with you, like the article from the website is giving the diagram in like horizontal way. I don't know in vertical way. I just flip it to be horizontal way, so it's easier in the mind, in your eyes to see. Okay. Then the same scenario, but like the fracture involving enamel, dentin, and bulb. Okay, crown root fracture extending into soft tissue beneath the gum line, and bulb is exposed. So tender to percussion for sure, it has a trauma here. So first of all, missing fragments should be accounted for. If you cannot find it, you do X-ray. What X-ray needed here is one per apical X-ray. Cone beam CT again is considered as the same scenario, so it's the same treatment, but here is a difference here. In immature teeth with incomplete root formation, it is advantageous to preserve the bulb by performing a partial pulpotomy. Rubber dam isolation is challenging but should be tried. So to this point, what it's telling you here, rubber dam is mandatory for any root canal treatment. Any root canal treatment, even for this patient after trauma, he's in pain, blah blah blah. Rubber dam is a must and should be tried anyway. Okay, and then you're gonna do a partial pulpotomy. Non-static calcium dioxide is to be placed, and then you place gossamer and the composite to build the tooth up. Immature teeth with complete root development, removal of bulb is usually indicated. So you're gonna ask me, okay, why we use here removal of the whole bulb, but the other one we're gonna remove like partial pulpotomy, even is complete root development. Okay, so scenario here make all the difference. In the other scenario, the bulb was exposed, but the fracture line was above the soft tissue. So you can see the fracture line here. The fracture line is going down. When the fracture line is going down, mean prognosis is not very favorable, so you should intervene with more. But in immature tooth, as we said, like the bulb vitality is the main goal here, so we should try to preserve it. But for permanent tooth, like, okay, so now the risk you're gonna give to your patient is more than a benefit you're gonna gain. Okay, and again, gossamer is used and then composite. Okay, treatment plan to be determined after cone beam CT, ortho extrusion, surgical extrusion, crown lengthening, and the follow-up should be done. Okay, So this is the difference between this scenario and the previous scenario. As I mentioned to you, it's the same scenario, but like adding more points to it. Okay, and then if the fracture is in the root itself, not in the tooth itself, no, in the roots, so X-ray should be done. And then if the missing part, this part is missing, you should look for it, take soft tissue X-ray. And then what the treatment here? So if displaced, the coronal fragment should reposition as soon as possible. If this one is going labial, going palatal, you should reposition it again. Stabilize a mobile coronal segment with passive and flexible splint for 4 weeks. If there is a fracture is located cervically, stabilization for a longer period of time, up to 4 months may be needed. So as the fracture go down, so you might need more time to do stabilization. But anyway, here the critical point is a flexible splint, passive flexible splint. As we said before, rigid splint is not anymore, okay? And then you should explain to the patient the favorable outcome, unfavorable outcome. And in this instance, in these cases, usually barbed wounds and infection may develop later. It usually occur in the coronal fragment only. Hence, endodontic treatment of the coronal segment only will be indicated. As root fracture lines are frequently oblique, determination of the root canal length may be challenging. An epixification approach may be needed. Okay, so what is saying here? Okay, so this patient came to you, you give a splint for him, he's good. He goes, come to you after 6 to 8 weeks. And you see signs of infection here, you see sinus tract, you see signs of infection here. So what to do now? So you should do root canal treatment. So which part you're gonna do root canal treatment? You're gonna do root canal treatment for this part only, the coronal part. The apical part, gonna leave it by itself to be there, just to preserve the space here. But as I mentioned here, like it's not easy to reach apical constriction here, so you can finish the root canal treatment here. So it's a challenging, so you might need to do epixification to make apical stop, so you can do root canal. Immature teeth where the cervical fracture line is located above the alveolar crest and the coronal fragment is very mobile, removal of the coronal fragment followed by root canal treatment and restoration with a post-retained crown will be likely required. Additional procedures such as orthodontic extrusion or apical segment crown lengthening surgery, surgical extrusion, or even extraction may be required as future treatment options. So again, in this scenario, it's complicated, so you should consider more than one factor, the fracture line, location of the fracture line. As we said before, if the fracture line is going to crestal bone, it's poor prognosis. As the fracture line is going away, near to the apex, is good prognosis. And this makes sense, honestly, because like if the coronal part is longer, it will be more stable and more easy to deal with. But if the coronal part is shorter, as the fracture line go more than the crest of the bone, so it will have not hopeless prognosis, but less favorable prognosis. Okay? Okay, if the fracture involves the alveolar bone, alveolar fracture is complete and extend all the way to the buccal or the palatal plate, palatal bone in the maxilla, and from the buccal to the lingual bony surface in the mandible. So the fracture will go like, see that the previous one, the fracture was in the only the palatal or labial. Here the fracture is going boom, getting from labial and palatal, extending all the way. In this way, in this case, for sure, occlusal disturbance due to displacement and misalignment of the fracture alveolar segment are often seen. Teeth in the fracture segment may not respond to bulb sensibility test. Make sure, because like makes sense, because the bulb here is away from its line. Fracture line may be located at any level from the marginal bone to the root apex. Recommended radiograph, 1 per apical radiograph, 2 X-ray may be done more, occlusal radiograph may be done here. Okay, first of all, repositioning of the displaced segment, because like you have now not dealing with root fracture, you are dealing with alveolar fracture. Stabilize the segment by, and this is critical, by splinting the teeth with a passive and flexible splint for 4 weeks. Suture gingival restoration, if present, root canal treatment is contraindicated at the emergency visit, because patient here has alveolar fracture. You don't start root canal treatment now. You give him a break, please. And then monitor the bulb condition of all teeth involved, both initially and at follow-up, to determine when to do root canal treatment. Follow up after 4 weeks for sure to remove the splint. And again, if you come back after 4 weeks, and the tooth is still mobile, you leave it. As we said, that's why we're using semi-rigid splint to not give the tooth a hard time about micro movement. And then, I don't know why this PDF is so laggy. Okay, and then again, we speak about it before, but like let's go through it quickly. Concussion and subluxation, we said before, like trauma leading to pain, but difference between concussion and subluxation. Concussion will have mobility normal, subluxation will have more than mobility. Like you have more than normal mobility for the teeth involved. This one, concussion X-ray needed, subluxation X-ray are needed. Passive is flexible splinting to restabilize the tooth for 2 weeks only may be used if there is excessive mobility or tenderness when biting on the tooth. But this is usually not indicated. Usually no treatment is needed. But like if the subluxation is severe, you may do splinting, but now for only 2 weeks. And then follow up 2 weeks, 12 weeks, 6 months, 1 year, favorable outcome, unfavorable outcome. Okay? And then we're gonna discuss the other situation. I think you might be familiar now about it. Extrusion luxation. Extrusion luxation means the tooth is going inside. The patient will say, okay, I feel the tooth is shorter now. The tooth appear, extrusive luxation. The tooth is coming outside. The tooth appear elongated. When you take X-ray, you see dark line between the tooth and the alveolar crest, alveolar bone level inside the X-ray. This means the tooth is coming outside. X-ray is to be done. Repositioning the tooth by gently pushing it back into the tooth socket under local anesthesia. So for this patient, it's permanent tooth, fully developed. So you give him freezing and then you push it back. You do splinting for only 2 weeks using semi-rigid or flexible splinting. A breakdown or fracture of the marginal bone is planned for additional 4 weeks. So here you should think about it. What happens? Like the tooth is coming out and the bone is fractured. So you're doing a splinting for 2 weeks for the tooth and you extend it for 4 weeks to make sure the bone is good. Okay? Monitor the pulp condition and then in follow up you go with everything, favorable outcome, unfavorable outcome. Okay? And here is important point here. Positive response to pulp sensitivity tests, however, a false negative response is possible for several months. Endodontic treatment should not be started slowly on the basis of no response to pulp sensibility testing. No marginal bone loss, continued root development in immature tooth. So let me acquire this again. So if the question mentioned, okay, patient come to you and a routine dental exam, and you are doing exam and the patient giving you history, okay, this tooth received a trauma 3 months ago, and you do a pulp vitality test, it's negative pulp vitality test. It's negative pulp vitality test. But there is no discoloration, there is no radiolucency at the apex, there is no signs of infection around the tooth. So what you do now? As saying here, false negative response is possible for several months. So you do nothing. You just wait and tell the patient the situation now. So you just wait for him. If, as we said before, there's apical periodontitis, breakdown of bone, external inflammatory like external root absorption or internal root absorption, then you should intervene. But as the tooth has nothing to be done, patient has no concern about it, you do nothing. You just monitor the tooth, okay? Because this is a weird scenario, but like you might see it. You might see these questions. And then lateral relaxation. Lateral relaxation is the same as previous, but this one, the labial part of bone is broken and the tooth is good. Displacement will be seen, and then you see step here. I think you can deal with this now. X-ray is needed. Widen BDL to the area the tooth displaced away from. So the tooth going labial, so you will see radiolucency lingual because the tooth is moving the other way. Repositioning in the tooth under local anesthetic solution for sure, and gently repositioning. Like you should take care of this one. You should do it gently under local anesthetic solution. It's not like no, you should give him freezing. Okay, and then stabilize the tooth for 4 weeks using a passive and flexible splint. If breakdown or bone is broken down, so you could to do more. Okay. Monitor the pulp condition, and the test is not reliable at this point for sure. And then at about 2 weeks post-injury, make endodontic evaluation. So after 2 weeks, you bring him back to the office. Teeth with incomplete root formation, spontaneous revascularization may occur If the pulp become necrotic and there is a signs of inflammation, infection-related external resorption, root canal treatment should be started as soon as possible. Endodontic procedures suitable for immature teeth should be used. What does this mean? So the patient came to you, you replace make the tooth into its position again, you do the splinting. He come to you after 2 weeks. After 2 weeks, if it's immature, as again, it's immature tooth, in some cases, spontaneous revascularization may occur and everything is good. But if the pulp becoming necrosed, so you should intervene now, you should do endodontic treatment. Why he didn't mention root canal treatment? Because it's immature tooth. If it's immature tooth, it's not root canal treatment. It will be epixification. So because the tooth is dead now, you cannot do epixogenesis. It's epixification, okay? Teeth with complete root development, the pulp will likely become necrotic. Root canal treatment should be started using a corticosteroid, antibiotic, or calcium hydroxide as intracanal medication to prevent development of inflammatory external resorption. Okay? Follow up 2 weeks, 4 weeks, 8 weeks, 12 weeks. I don't know why they put all these numbers, honestly. But here you should go for this one. As we said again, this point is critical. Please pay attention to this one. It's not about only the pulp vitality test. If a question giving you a scenario, you did epixogenesis and the root development is good and the root is developing and you take x-ray and the tooth is good, but the patient, when you do the initial treatment and when you do the follow-up session, you see the bulb is necrotic. Not necrotic, the bulb is not responding to bulb vitality. You do cold test, it's negative. But the root is developing, there is no signs of infection, there is no radiographic change, you do nothing. It's good. It's good. It's not like we are doing miracles about the tooth. Like if we reach a good point, tooth is developing, the root is continuing, you see dentin deposition inside the canal, the root canal itself is getting narrowed, dentin is good, so you leave it. You do nothing for this one. Okay? Intrusive luxation, intrusive, this is the other one. Intrusive, the tooth will be shorter. The tooth is displaced axially into the outer bone. Percussion will give you high metallic sounds. And then x-ray should be done. And then periodontal ligament space maybe not be visible. When you take x-ray, the tooth is enclosed, like there is no PDL here now space. Teeth with incomplete root formation, immature tooth. For immature tooth, you allow re-eruption without intervention. Spontaneous reposition for all intruded teeth, independent of the degree of intrusion. If no eruption within 4 weeks, initiate orthodontic repositioning. Okay, so there is a new concept here. So you look for the tooth. First of all, it's intruded before we should start root canal treatment. No, now we do nothing. We do nothing. Allow re-eruption without intervention, spontaneous repositioning for all intruded teeth, independent of the degree of intrusion. So if the question is saying 5 mm, 6 mm, you just wait. Okay? But if no re-eruption within 4 weeks, initiate orthodontic repositioning and monitor the pulp condition. In teeth with incomplete root formation, a spontaneous pulp revascularization may occur. However, it is noted that the pulp become necrotic and infection is here, so you should intervene as always. Okay? So this is a scenario for incomplete. Scenario for complete. Tooth with complete root formation, mature tooth, allow re-eruption. Again, so you do nothing. Either immature, mature, you do nothing. Allow re-eruption without intervention. If the tooth is intruded less than 3 mm. If no re-eruption happen within 8 weeks, reposition surgically and splint for 4 weeks with passive flexural splint. Okay? So again, its numbers here are different. So if it's intruded, immature tooth, open apex, you leave it, you do nothing. After 4 weeks, he come back to you and then check. If it's not re-erupting again, you help the tooth with orthodontic repositioning. But if it's permanent, it's intruded. More than 3 mm and no, less than 3 mm, and you book him back after 8 weeks and nothing is happening, so reposition surgically and splint for 4 weeks with a passive and flexible splint. Or reposition orthodontically before ankylosing develop. If the tooth is intruded 3 to 7 mm, reposition surgically, preferably, or orthodontically. And now I believe you can see the difference. Ortho extrusion is indicated for both, but it's more favorable, like up to 3-4 mm. If you go to 7 mm, surgical is the favorable line of treatment here. If the tooth is intruded beyond 7 millimeter, reposition surgically immediately. You don't need to wait for anything. In teeth with complete root formation, the pulp almost always become necrotic. Root canal treatment should be started at 2 weeks or as soon as position of the tooth allow this. Okay, so there's a scenario again. If the tooth is short, you may take X-ray, make sure it's shorter, and then giving you metallic sound, you check. If it's immature, you just wait for it to repositioning. After 4 weeks, coming back. No repositioning or orthodontic treatment. Or if it's complete and it's less than 3 millimeter, you wait for 8 weeks. If it's not, you take it out with orthodontic extrusion. If it's intruded 3 to 7 millimeter, you're repositioning surgically or orthodontically. If the tooth is intruded beyond 7, you reposition surgically immediately. You don't need to wait. 7 millimeter is too much. No one can do this. Okay. So here he's going to wrap up everything. I hope now you have the scenario in your mind clear. You can go back to the video again to check everything, put your notes. I'm going to recap everything for you here. Okay, so he's saying here the use of clinical photograph is strongly recommended because patient forgot what the tooth was colored when he come to you, assessment of tooth discoloration and stuff like this, re-eruption of intruded tooth. You're telling the patient, okay, tooth is good, no, he's saying no, so you give him the picture for the baseline you did before. Here we speak about like lack of response to pulp testing. Okay, testing might be unreliable due to what? Transient lack of neural response or undifferentiation of A delta nerve fibers in young teeth. So he's speaking now about like permanent immature tooth. So here, transient, it will give you false negative. Why? Transient lack of neural response or undifferentiation of A delta nerve in the young patient. The temporary loss of sensibility is a frequent finding during post-traumatic pulp healing, especially after luxation intrusion. Thus, the lack of response to pulp sensibility testing is not conclusive for pulp necrosis in traumatized teeth. Despite this limitation, pulp sensibility testing should be performed initially at each follow-up appointment in order to determine if changes occur over time. It is generally accepted that the pulp sensibility testing should be done as soon as practical to establish a baseline for future comparison testing and follow-up. Yo, I lost you now. Okay, so let's take a deep breath and explain what he said now. Okay. So pulp testing, there is different types of pulp testing. There is cold, hot, and electric pulp testing. Hot is not to be used anymore. We don't like to use it. Cold, we usually use a cold pulp testing. He's saying here, because of the trauma, it may give you negative, which is false negative because of what he mentioned here, lack of neural response or undifferentiation of A delta nerve fibers. So what, and then he mentioned like you should do a pulp testing. So it's confusing here how I should and it's not reliable. Then come the benefits of the electric pulp testing. Why electric pulp testing is indicated here? Because electric pulp testing has a baseline you can use as a baseline, meaning electric pulp testing, when you do it, it gives you number from 0 to 80. So what you do with this, you put the probe of the electric pulp testing on the tooth and then you start it. You increase the current, like increase it from 20, 30. Usually the normal teeth give you response around 30, 20, 40, this range usually. But for this traumatic tooth, you should increase it 60, 70, and then you record it. So it gives me a response at 70. It gives me a response at 60. It didn't give me any response even at 80. 80 is the maximum. It didn't give me any response even at 80. This you record at first visit. He come to you after 2 weeks. You do it again. Give you the same result. Or it might give you a response at 80. And then he come to you after 4 weeks. Or he come to you after 3 months as a follow-up schedule is saying, okay, it give me response at 70. So before it gave me at 80, now at 70. So this is the meaning of baseline. So now you can say, okay, I can see a progress. I can see the tooth is trying to save itself, not asking me not to intervene. I will be okay by myself. So this is the meaning of this part, because I think this part is confusing. Honestly, it was very confusing for me when I read it first time. Okay. And then stabilization, we said like it's short time passive, flexible splint are to be used, and we said like 2 weeks to 4 weeks, depending on the situation itself, what we use a stainless steel wire up to 4.4 millimeter in diameter. Splinting is considered best practice. Why? Why? This is honestly this is funny. Splinting is considered best practice in order to maintain the repositioned tooth in its correct position and to favor initial healing while providing comfort and controlled function. So, if a question asking you why we do splinting, it's patient comfort. Patient comfort is the key point here. We're doing it for the patient comfort, and honestly, it makes sense, honestly. But like for me, it was funny at the beginning. So we should give patient comfort because like the tooth is moving. So when you do printing for the tooth, you give it as a dentist. You think from your perspective, I'm trying to save the tooth, splinting it, giving it time to heal again. But for the patient, it's giving him comfort because like if not splinted and he's eating, it's very painful for him. Okay. It's critically important to keep composite and bonding agent away from gingiva and proximal area to avoid plaque retention and secondary infection. This allows better healing of the marginal gingiva and bone. Splinting time duration may depend on the type of the injury, and we speak about this one is 2 weeks or 4 weeks according to the situation you have. Okay, and here's one more point I should mention. Oh yeah, if you are planning to do root canal treatment for the tooth, like for avulsion, for this type of fracture including the bone, lateral extrusion, so lateral luxation, so in this case you're doing the splint from the labial side. Why? Because the splinting will be here for 4 weeks at least, and you might need to do root canal treatment after 2 weeks. Why I might need to do it? So after 2 weeks in the follow-up session, if he come to you with signs and symptoms of infection, swelling and pus, stuff like this, so you should intervene now. You're not so no, we are gonna wait 4 weeks. No, you have some signs now. You should intervene now. So how are you gonna do the access? You do the access from the palatal side. So anyway, you do the splinting from the labia side using composite and stainless steel wire as mentioned here. Okay, use of antibiotic is limited. There's limited evidence of use of systemic antibiotic in the emergency management of luxation. Antibiotic is indicated only for avulsion and might be here, but like avulsion is totally indicated. Okay, patient instruction should be done carefully and follow up with him, giving him like the favorable outcome, unfavorable outcome, he should know it. Okay. Again, here the rationale about this article in this point. Every effort should be made to preserve the bulb in both mature and immature teeth. In immature permanent teeth, this is of utmost importance in order to allow continued root development and apex formation. Continued root development. He didn't mention anything about bulb vitality. Continued root development, we are good. The vast majority of traumatic dental injury occur in children and teenagers, where loss of tooth has a lifetime consequence. The bulb of immature permanent tooth has considerable capacity for healing after a traumatic bulb exposure, luxation injury, or root fracture. Bulb exposure, secondary traumatic dental injury are amenable to conservative bulb therapies. So why I'm reading all this? To give it back to you, to dig it deep in your mind. We need to preserve the bulb vitality. How are we going to do it? By bulb capping, partial pulpotomy, shallow or partial pulpotomy, and cervical pulpotomy, which aim to maintain the bulb and allow for continued root development. Okay? I think that's it. I hope that was beneficial for you. Get your notes, try to answer the questions. Feel free to watch the video again. Leave me your comment. If you have any feedback, leave it for me and feel free to share it. Thank you. Have a good day.